Hello, I'm Dr. Rafael Escamilla, professor in the Doctor of Physical Therapy program and director of the Biomechanics Laboratory here at California State University, Sacramento. Today we're going to be talking about the structure, function, and pathology of the median nerve. Its origin is the brachial plexus, specifically the merging of the lateral root of the lateral cord receiving C6, C7 fibers, and the medial root from the medial cord receiving C8 and T1 fibers. So the median nerve is a C6 to T1 mixed peripheral nerve. Mixed meaning it contains both motor and sensory nerve fibers. So I want to first give a summary of each. So let's start with the summary of the motor function of the median nerve. So these are the muscles. So when you think of the median nerve, you have muscles in the anterior compartment of the forearm and the lateral hand. So there's 8 muscles in the anterior compartment of the forearm, 4 superficial, 1 in the intermediate layer, and 3 deep. The median nerve innervates 6.5 of those 8, so almost all of them except for the medial 1.5 muscles. So the way you remember the 4 superficial muscles is put your web space into your medial epicondyle. That reminds you that's the origin of these 4 superficial muscles. And the fingers running down the forearm represent the forearm muscle. The little finger is going down the medial side. That's the flexor carpi ulnaris. That is the only superficial muscle that is not median nerve. It's ulnar nerve. It's going to go down to the base of the 5th metacarpal and the pisiform and flex the wrist and ulnarly deviate. So that will be spared with a median nerve pathology. The next 3 are all median nerve of the superficials. The ring finger represents the palmaris longus. It's absent in about 10 to 15% of the population. Its tendon's right pretty much in the center of the wrist. So if you don't have one there, then you may not have one. And then it's going to go into the palmar aponeurosis and tense the fascia of the palm and also can help with flexion of the wrist. It's primarily going to be innervated by C7 and C8 as well as some C6. Then the middle finger is represented by the flexor carpi radialis, and its tendon is just lateral to the palmaris longus. It's going to receive C6, C7, primarily C7 nerve fibers. It's going to come down and insert into the base of the 2nd and 3rd metacarpals, crosses the wrist anteriorly and laterally, so it flexes, and radially deviates the wrist. Flexion and radial deviation. So that's the flexor digitorum, or flexor carpi radialis. And then the last finger, which is the index finger here, now we'll let the others disappear for a second. This is the pronator teres. So it actually has 2 heads, one at the medial epicondyle, like we said, and 1 additional head at the coronoid process of the ulna. And it's going to go about 1/3 of the way down the radius and insert into the radius. So because it's on the radius, it can pronate, force vector pulling in this direction. Part of the force going this way is going in the medial direction, so that will pull the radius over the ulna. So it's your most powerful pronator of the forearm. So those are the 3 superficial muscles innervated by the median nerve. Again, remember the 4th one is ulnar nerve, the flexor carpi ulnaris. And then you also have 1 muscle in the intermediate layer, and that's the flexor digitorum superficialis. That also has 2 heads, a humeral ulnar head on the medial epicondyle and the coronoid process of the ulna, and a radial head. And then it's going to come down under the transverse carpal ligament, known as the flexor retinaculum, through the carpal tunnel, and the tendons are going to insert into the base of the middle phalanx of the lesser 4 fingers here. So it can flex the proximal interphalangeal joint, known as PIP. One way you can test for it is doing this maneuver, where you stabilize the 3 of the lesser fingers, use the middle finger, and then go ahead and flex PIP, like you see me doing, while you keep dip nice and relaxed. So this is the function of the superficialis. You want to make sure you keep this distal interphalangeal dip from flexing, because that's the action of the flexor digitorum profundus. So that's how you can, another way you can do it is you can stabilize the proximal phalanx and then flex PIP up like this way. And actually you can feel the tendon right in the middle of your hand. when you do that. So those are the four muscles, 3 in the superficial layer and 1 in the intermediate layer. That leaves 2.5 more because it innervates 6.5 of the 8 muscles. So the remaining 2.5 muscles are the deep muscles, and those are going to be the flexor pollicis longus. So it originates in the middle third on the radius, and it's going to come down again under the transverse carpal ligament in the carpal tunnel, deviate, follow the thumb, and insert into the base of the distal phalanx. So it's in good position to flex the IP joint like this. So you stabilize the proximal phalanx and have them bend the distal phalanx. So you're flexing the IP joint, and that's an intact flexor pollicis longus. The second deep muscle is the flexor digitorum profundus, but the median nerve only innervates half of it. So that's why we say it innervates 6.5 of the 8 muscles in the anterior compartment. So it innervates the half that controls the index and the middle finger right here, the lateral half. And this muscle originates on the proximal ulna and the interosseous membrane. It again is going to go down through the carpal tunnel, under the flexor retinaculum, and it's going to go under the superficialis tendons until it gets into the fingers, and then it's going to come up through a slit in the superficialis tendons and insert into the base of the distal phalanx. So it flexes DIP, the distal interphalangeal joint. The way you assess for it is you stabilize the middle phalanx and have them bend the distal phalanx, so flexing DIP like this. This shows an intact flexor digitorum profundus. So only the 2 lateral fingers, the 2 medial fingers of the profundus is ulnar nerve. So those are your 6.5 muscles, and collectively it's helpful to know these muscles are called the flexor pronator mass. It's descriptive of what they do. They flex the wrist, they flex the fingers, they flex the thumb, and they pronate the forearm. So if you have an injury to the median nerve, a high median nerve injury, before these muscles get innervated, so that's going to be an injury up in the arm, and we'll talk about that next, it could affect all the flexor pronator mass muscles potentially, and then that's when you're going to have weakness in wrist, finger, and thumb flexion and forearm pronation. In addition to the 6.5 muscles in the anterior compartment, it's also going to travel under the carpal tunnel, and it's going to innervate the 3 muscles in the thenar region that control the thumb, actually only 2.5 of the muscles, because it only gets the superficial part of one of them, and the lateral 2 lumbricals. So let's talk about those briefly. You have 3 muscles in the thenar region. They all originate on the lateral flexor retinaculum and the lateral carpus, which is your trapezium and your scaphoid. Then the most radial side, you have the abductor pollicis brevis, which is going to abduct the thumb. Abduction of the thumb is bringing the thumb up this way, but it only does it at the metacarpal phalangeal joint, which is this joint right here. And then just on the ulnar side of that, right in here, is the flexor pollicis brevis. So this is the one that has 2 heads, and it's only going to innervate the superficial head. The deep head is innervated by the ulnar nerve. So that's why we say 2.5 muscles in this area. It's going to come up and insert into, again, the base of the proximal phalanx. So it's in good position to flex the thumb or bring the thumb across the hand, but again, only at the metacarpal phalangeal joint. It doesn't cross the interphalangeal joint here. That's the flexor pollicis longus that we talked about. So it's only going to flex right here at the metacarpal phalangeal joint. So that's the flexor pollicis brevis. And the last one is the opponens pollicis, which inserts into the most of the length of the first metacarpal in here, and it's going to help oppose the thumb over to the little finger or any of the fingers for that matter. So that's opposition. So if you have an injury to the median nerve, especially a high injury or even one in the forearm, then it can potentially affect the function of the thumb from these 3 muscles. Your thumb is your most important digit for hand function. So if you've lost the ability to flex and abduct and oppose the thumb, potentially your hand is going to be, at least to some degree, dysfunctional. And then the last 2 muscles are the lateral 2 lumbricals. Okay, these are worm-like muscles that originate on the tendons of the flexor digitorum profundus that we talked about recently, and they're going to come up and insert into the oblique fibers of the dorsal hood, which is part of the extensor mechanism, and the base of the proximal phalanx. Because they're coming down this way on the palmar surface, they produce a torque that flexes the metacarpal phalangeal joint, because they're coming below, as you see here. But because there's tension in the oblique fibers of the dorsal hood, that tension is transferred up to the extensor mechanism through the central band, which comes through the dorsal part of the proximal phalanx, inserts into the base of the middle phalanx, and the lateral bands that come off of it, and the terminal tendon that inserts into the base of the distal phalanx. So tension there can produce a torque that will extend pip and dip. So therefore, the function of the lumbricals is to flex the metacarpal phalangeal joint and extend pip and dip. Basically assume this lumbrical grip. It's called a lumbrical grip. It's commonly used by clinicians in manual therapy, such as proprioceptive neuromuscular facilitation, PNF. And this is the sign for it. So if you have a dysfunction of the median nerve, when you ask them to do a lumbrical grip like this, these two fingers may not be able to do it very well compared to the other two fingers, because the two medial fingers over here, these are ulnar nerve, where the two laterals are innervated by the median nerve. So that's a summary of the motor function. Now let's do a summary of the sensory function of the median nerve. It's really quite simple. It innervates the skin, supplies the skin on the lateral, 3.5 fingers, and hand. Primarily on the palmar surface, but it also wraps back around on the dorsal surface of those same 3.5 lateral fingers, but only the distal phalanx, so the nail beds. So we're talking about the thumb, the index, the middle finger, and half of the ring finger, and the lateral hand, the thenar region, and the central palm as well. You have a higher density of sensory receptors in the pads of the fingers. So if you have an injury to the median nerve, then you're more likely to experience numbness, pins and needles, tingling sensations more in the pads than you will other parts of the fingers and the hand. But potentially you could experience it everywhere if you had a bad enough injury. So that's a summary of the sensory function. So that gives a nice overview of both the motor and sensory function of the median nerve.